we expect that the donut hole will get closed?
So the donut hole will be closed in 2020. Right now it's been kind of halfway closed through discounting. So basically what happened is 2010 there's a $250 rebate issued to anybody who went into the donut hole, which is this what's often called the coverage gap. So it's in the amount roughly over $2,440. If you spend over that amount in Medicare, coverage goes away through your Part D plan after that amount. So people were responsible for about $4,000 of coverage gap. So part of that was replaced in 2010 with this $250 rebate, and then it's being shrunken over the years until 2020 when it goes away through kind of a deal that was made between pharma and the administration.
Carol?
Yes. I mentioned this client and how I had to go through 3 layers, Medicare down to a healthcare provider, down to somebody they had outsourced to, and then a fourth. Now, if they are restricted to 80% for direct patient care, how can that possibly be? Because if they're going to be farming it out, every one of them takes some profit from that.
Right. So this is an interesting question. So one is that they're not restricted to 80%. They have to be 80% or better. So if you look at Kaiser Permanente, usually their medical loss ratio is in the 88% realm. Now, one of the things that health plans will do is they would rather capitate their entire risk down to a medical group and say, okay, we're going to pay you $1,000 a month. Like in Medicare Advantage, usually the benchmark rate is around $1,000 a month. So they could just find one medical group that has a bunch of hospitals and providers in it that's willing to take $800 a month for a capitated rate, and they've now met medical loss ratio because they're passing on all of their risk to that group.
And it means there's an ethical issue with providers. The fewer people you treat, the more you make. It's a very bad system.
Yeah, and I think it's an issue we've been dealing with since the early 90s in California with managed care, with HMOs. What has happened though is providers in California especially have pushed back quite a bit. So you ended up with the shops, like the big IPAs that were willing to take on all this risk for a very low amount of money, either going out of business or saying we can't do that anymore. And now we might be at a level at which provider groups are more empowered to manage a patient population. So you have electronic medical records, you have a chronic care model, you're doing certain innovations. So healthcare partners or something like that comes to mind, where you have IPAs that work a little bit better than they did 20 years ago. And so, we have to be cautious that we don't replace efficiency with bad quality. We kind of have to merge efficiency and effectiveness together in some way. And so the way Medicare Advantage would work is that they would say, okay, fine, you can subcapitate all your business to this medical group, but you have to hit these certain quality benchmarks. And if you're not getting 3 stars or better every year for the next 5 years, Medicare has the option of canceling your contract. So there's a lot more teeth that CMS will have in terms of overseeing those Medicare managed care plans. And so hopefully we won't see as much waste and abuse in that program as we saw before 2010.
One more question. How are private practitioners like Steve and I, how are we going to stay in business if they're going to be encouraging these network groups? I forget what the name of them are, but
Accountable care organizations.
Accountable care organizations. How do we stay in business?
So remember that accountable care organizations are really designed for the Medicare population. So, if we think about it, even though Medicare is a very vocal constituency and it costs a lot of money, it's 15% of the entire population. So it's a small program in comparison to Medicaid and in comparison to private insurance. So it's really an attempt to kind of get providers to work together, and lots of, like Healthcare Partners, for example, has been trying to sign up kind of private practice providers with their own shingle that have no electronic medical record, and trying to get them to sign up because of the fact that these networks are now taking on risk for a population they used to just churn through with managed care or with Medicare fee-for-service claims. So if you have so the way the ACO model works is that every provider that develops an ACO would be responsible for at least 5,000 patients in an area. And like let's say one of you lives in the middle of Beverly Hills next to Cedars-Sinai, and you are technically enrolled into Cedars ACO. You actually aren't required to go to Cedars for any of your care. If you go outside to UCLA, Medicare will pay for your care, you'll get it without any problem, your cost sharing will be the same, nobody will call you and bother you, but Cedars is actually going to suffer because of the care you used at UCLA, because that amount of money you spent over at UCLA is still going to be counted against them in that budget that CMS is holding them to. So they have an incentive to keep you happy, but also expand their provider network to include all of the people that provide care to all 5,000 people. So they would want to sign up specialists and private practice docs in that area. So Healthcare Partners in South Bay and Orange County has been like giving signing bonuses to physicians, giving them free medical record access through a web-based portal, and trying to give them supports that they haven't gotten in private practice before. So we'll see how that works. There are only 250 in the country right now, and they're not rapidly growing. They have to go through processes to get approved by CMS, and they're required to report on 36 different quality measures every year that make them continue in the program and make sure they're not kind of diminishing care. But I think the writing on the wall is around integration and making sure you have health information technology, making sure you can actively refer and get follow-up advice from people within an insurance network. And I think that was the case in California for many years with health maintenance organizations and this managed care model. But that isn't to say that in the exchange you can't go in and sign up for a PPO and you can't use whatever provider you want to go to as long as you're willing to pay the extra out-of-network cost for that. Yes?
So I want to piggyback on Carol's question and then maybe add one more. She was asking like, how are we going to cope with this? And I think she was referring to capitation. In the 90s, I had set up an IPA, Independent Psychological Association of 12 of us. And we were capitated with a few contracts from some of the mental health organizations, I think Value Options, maybe United Healthcare. And then there was a ruling that basically psychotherapists can't be capitated because it puts us in a dual situation. We can't have duality with our clientele. We can't earn money. We can't earn money by sending them away so that we could profit. So it really, the model that you're speaking of, or they're telling you this is about for mental health, really won't work. I think it's against the law.
Well, so the ACO regs specifically kind of relax Stark anti-kickback law. So I don't know if this will ever end up in court, but CMS basically said, don't worry about Stark issues, we'll make this work because it's a pilot program. And technically under a pilot program, CMS has the statutory authority to keep expanding it as long as it's meeting the goals of the ACA, that it's cost neutral and it's not harming Medicare patients. So they kind of have this wiggle room to not invalidate Stark, but skirt those anti-kickback self-referral laws that may have ended up in that ruling.
Yeah, but it wasn't so much about kickback as much as it was having a dual relationship with the client.
Right, but I mean the kickback ends up, like the way Stark has been enforced over the years has really taken a hit with referrals. So like if you're referring out to a provider outside of the network, it's not considered a kickback. But if you are part of the same integrated delivery system and you're all not under the same roof, then they had kind of, that could run afoul of the law. So Kaiser Permanente never had that issue because of the fact that they're this all-inclusive place that can refer as much as they want. They're all under a capitated contract. Whereas if you have all these separate capitated contracts, some doing fee-for-service, some not, then the federal government has always been kind of skeptical of it. And for the past 5 years or so, or 3 years, they've basically said, don't worry about it in the context of accountable care organizations.
Okay, so one last one, I'll give other people a chance. I don't know if many people in this room know that the fees that are paid to psychotherapists have basically been about the same as they were when I first saw a therapist in 1979. I mean, Blue Cross paid $85 back then for psychotherapy, now they pay like $70, and overhead's gone up tremendously since the 1970s. The insurance companies are exempt from antitrust laws, and I'm wondering if there's anything on the frontiers with ACA to de-exempt them and make them work like any other business in this country, so that they don't continue to fix the fees.
Right. Well, I would say that insurance companies aren't specifically exempt from antitrust laws. The federal government just said we're not going to enforce them because we assume states are doing a good job. So McCarran-Ferguson doesn't exempt them from antitrust, it just says we're going to defer to the states on this. So really it ends up being a state consumer affairs issue, State Department of Insurance issue, and I suppose you could pursue it in that vein. ACA doesn't do anything because ACA basically said the federal government is agnostic to antitrust issues for health insurers because McCarran-Ferguson has existed for the last 60 years. So I don't know if there's a lot of recourse to expect from the ACA. I think what recourse you do have is the fact that you have potentially, 3.5 million people coming into health insurance networks in fairly short order. And the essential health benefits package includes mental health providers and mental health benefits, including psychotherapy and counseling and all these things. Medicaid itself, Medi-Cal, has decided to expand the role of managed care companies in delivering Tier 1 and Tier 2 kind of basic primary care and counseling services, and requiring that they do these carve-outs for specialty mental health. And other states are probably going to do like the bare bones approach and not cover certain things. So Medi-Cal has been rather aggressive in making sure mental health substance abuse services are available. The essential health benefits package includes them. And now you have 3.5 million new customers that need them. And because everybody's in these managed care firms that are regulated by state managed care agencies that have to meet network adequacy requirements under Knox-Keene, you now can kind of force insurance companies to negotiate with you because they need to meet their network adequacy standards in different areas. So it'll really play out differently where you're located. I would assume in this area, you may have higher leverage because of the fact that they're putting together a network of mental health professionals that they haven't had to do before in any meaningful way, and you can now get them to play ball. But in some areas, I don't know, in Beverly Hills or near UCLA, they'll probably say, well, we have a list we have the entire UCLA medical group in our network, and even though half of them are faculty members who don't do a single hour of clinical practice, we're counting them as providers in our network and we meet network adequacy. So I think it'll depend on where you're located and like which insurance companies are servicing this area. But I would really look at trying to join Medi-Cal managed care networks and the exchange networks to see if you can kind of carve out more business for the newly eligible population.
I've got a few questions here from different folks. Who and what is not covered? I think I've got a fairly good idea as to what's not covered. I'm not going to be getting any of my reconstructive stuff or my
so not
update
covered,
my face.
So I'll start with the hard question. So not covered would be dental and vision are not subject to the Medi-Cal benefit package or the insurance exchange essential health benefit package for adults. So children, they get oral care, vision care immediately upon signing up through the essential health benefits, either through a plan delivered directly with the health plan you sign up for or with an add-on standalone plan. So in theory, Delta Dental could sell their own product in the exchange and you could buy that with Kaiser Permanente. But as an adult, you won't be able to use your tax credit subsidies to buy the Delta Dental plan. You can only use them to buy the Anthem Blue Cross plan that has healthcare in it. For children, you can use the advanced premium tax credit subsidies to help you buy those plans, the dental plans, and vision plans. On the Medi-Cal side, right now, if people sign up, they won't have dental services until, I believe, May or June at this point. But Daryl Steinberg was very kind of passionate about getting the dental benefit package back into Medi-Cal that was taken over. So adult dental will be covered again in Medi-Cal starting in June, I believe. And depending on which county you're in, it'll be managed care. So who's not covered? Basically the undocumented are not covered. So I know I forget the guy's name, Joe something or other. who shouted that Obama was a liar during the September.
Joe Wilson.
Joe Wilson, yes. He was incorrect. So undocumented immigrants are explicitly forbidden from joining the exchanges. They can't even use their own money to buy exchange policies. However, they are somewhat protected if they have enough money to pay full premiums. And actually the premiums are pretty low for younger people. So if you have like an undocumented 25-year-old, the premium might be $150 a month or something like that, fairly low, depending on which plan you buy, and even lower if you buy like a bronze plan. So they're not allowed to take subsidies, but they're still protected by guaranteed issue coverage. They're still protected by the same age rating factors, still protected by all those elements that come to the individual market. They're not allowed in Medi-Cal. However, a lot of you know that we have emergency Medi-Cal in California that basically allows undocumented immigrants to get presumptive eligibility and kind of temporary episodic eligibility to pay for one hospital stay while they're there if they show up in the ER. And I would anticipate that that might increase a little bit because of the fact that the eligibility standards are getting ramped up to 138% of FPL, and it's available for childless adults. So right now, if you're a 25-year-old undocumented male and you go to the ER, they're not going to cover you under emergency Medi-Cal. They're going to try to get you into a Healthy Away LA or a county indigent program. Whereas if you're a mom and you show up, you can get presumptive eligibility and get emergency Medi-Cal. That would change in 2014 because of the fact that the childless adult restriction goes away, and basically the hospital just has to go through the process of getting your income, and even if you're undocumented, they can give you that presumptive temporary eligibility for Medi-Cal to get the bills paid for that visit alone. And then once your application goes through, you get rejected and you can't come back to Medi-Cal again. But it deals with the episode. One aspect to think about is the fact that legal permanent residents without 5 years of residence in the US are locked out of federal Medi-Cal or Medicaid. California has always put in money themselves into state-funded Medicaid for people who meet the same income criteria, but the state pays for the entire bill. Now, technically with the Affordable Care Act, anybody who hasn't lived here for 5 years but is a legal resident is still allowed to take tax credit subsidies in the exchange, but they're not allowed into Medi-Cal. So what Medi-Cal is doing is to kind of keep the spirit of state-funded Medi-Cal for this legal permanent resident population, is they're going to pay for the premium on behalf of the legal permanent resident less than 5 year member who isn't allowed into Medi-Cal but is allowed into the exchange. So if they go to the exchange and it's a $500 premium, they would typically look at the chart, and based on their income, they would get a $300 tax credit from the feds, and they would pay $200 out of pocket. In that case, California will come in and pay the $200 on their behalf, rather than put them into state-funded Medi-Cal and have to pay all of the costs for that population on their own. So that's something California is doing kind of differently than other states might be doing. I'm sure I'm forgetting some other groups, but.
Okay, isn't there a new tax going into effect on employer plans that exceed a preset level?
So in 2018, if you are in a policy that has an individual premium of $10,200 or a family premium of $27,500, any amount over that would be subject to a 40% excise tax called the Cadillac tax or the Maserati tax by some. It was Cadillac when it was like 8,000 and 24,000. Now it's Maserati because 10,000 and 27,000. So the idea is, let's say you sign up for Blue Shield PPO with no deductible, no cost sharing, the most robust health insurance network you've ever seen, and it costs $11,000 a year for a single person. So in 2018, that $11,000, the $800 gap between $11,000 and the threshold of $10,200 that flags a Cadillac plan will be taxed at 40%. So you would basically have to kick in another $320 on top of that 11. So your premium would go from $11,000 to $11,320. It's not a huge deal, especially if you're in a job that offers you benefits that generous. Typically your wages are high enough or your cost sharing is high or low enough that it's worth it to you to pay the extra $300, because you're not getting taxed 40% on the entire value of the plan, just the amount over that $10,200 threshold. to give you an idea, right now in 2014, a typical employer plan for a single person is like $5,600 a year. So basically you're saying if we double by 2018 the amount of premiums, then you would pay a little bit of tax on top of it. So there aren't many firms that have that, except maybe some CEO policies, and some labor unions kind of fought against it because of the fact that they've traded off for years wages for benefits.
Right.
Okay, the next question is, what is the best path to single payer? Is it public option?
So, federally or state?
Who will then know?
I'll take both. I'll say federal first. Best path to single payer. Probably a largely Democratic Senate, and you had the biggest majorities that we've seen in modern life in 2010, and this is what you got, right? So you know that when you get a filibuster-proof majority in the Senate that's made up of Democrats, you have to make some deals, right? You end up with Ben Nelson and Mary Landrieu and all these people who are still fairly conservative, but they happen to be in the Democratic Party. So I don't know that there's a lot of opportunity for single payer on the federal side, unless we end up there on accident. So I think the recipe for single payer is partially context of what happens with the ACA implementation. So we know that employers are looking at loopholes. They're gonna have, some of them are looking into 29-hour-a-week employees, but now 29-hour-a-week employees don't go uninsured anymore, right? They have a low enough income that they now go to Covered California, and they get very generous tax credits to help them buy insurance. So you're no longer dealing with this issue of, my employer dropped coverage and now I'm uninsured and I can't get another job because I need one that has health insurance benefits and I can't take a part-time one. Instead, you end up with people who may be underemployed, but at least they have health coverage now, either through Medicaid or through the exchange with really generous tax subsidies. So the exchange now offers this option that people didn't have before, and it's a guaranteed issue market. So if you sign up during open enrollment or any life change, just as you would with an employer plan, you're guaranteed these controlled premium prices and these fairly generous subsidies. And right now, in the 17 states that have issued exchange pricing, it's all been very attractive, right? It's cheaper than what we see on the employer market for the same plans, for Anthem Blue Cross HMO, for Health Net, etc. So if the exchange ends up being this attractive place to go, and employers want to continue dropping coverage because insurers feel like the only place where we can make money is in the employer market, and premiums are going to keep going up year after year, even though the exchanges have been very successful in keeping them down, then employers could start dumping coverage into that individual market, into the exchange, and all of a sudden you end up with lots of people in Medi-Cal, you end up with lots of people in the exchange, but at least they have coverage. And then when the federal government is in the business of funding all those tax credits for exchange eligibles, they have a lot more strength, right? They then can negotiate with insurers and drive costs down. And if that's unsuccessful, you could end up with the federal government and others saying, well, maybe we do move to single payer. But I think it happens like in 20 years if they find that employers bail out of the employer-based market, dump everyone in the exchange, and we're having a hard time allowing the federal government to use those tax subsidies as leverage to get exchange premiums to go down. If recent experience is any indication, the federal government could be very successful in that regard and could actually push premiums down as much as they want. And then this tension comes up about the network, the plans willing to play, the quality of the plans, workforce, insurance reimbursement, all of those issues. And if all of those things blow up at the same time, who am I to say that single payer won't exist? I didn't think that any healthcare reform would pass in my lifetime, and I'm not that old yet. I do have lots of gray hair, but it's mostly caused by work because I'm in this field. On the state side, I think there are lots of opportunities, right? So we already have this law that's gotten through, SB 840, SB 810, whatever you want to call it, the Leno/Kuehl single payer bill, that's gotten through, I think, 3 different sessions of the legislature and always vetoed by the governor. Now, there's no reason to believe Jerry Brown would sign it if it came to his desk again, but there's still a grassroots movement around single payer, around SB 810, SB 840, and that kind of version of single payer. And so that single payer law is very much based on the federal government signing off on using Medicare dollars, Medicaid dollars, and allowing for state flexibility in using the federal dollars that are flowing into the state, but also on using money from insurer fees, or basically like employer fees, to pay these quasi-insurers to run the benefit, right, with this very strict price controls. So what could happen though in 2017 is all of a sudden the federal government is willing to play ball, because the ACA says, if you can prove that you're going to have the same level of uninsurance, you're not going to hurt quality, you're not going to spend more money, and you're going to have satisfied patients, we'll allow a single payer provision, or we'll allow a single payer delivery system in your state. But now, instead of just Medicare and Medicaid dollars on the table through a federal waiver, you're looking at all of the tax subsidy dollars that are coming through the exchange that are, there right now. And so the amount of money coming into the state through the federal government to fund it gets a lot bigger. So all of a sudden the budget you're working with is different. You have to charge employers less, and so you might see more, ability to get that done in 2017 and beyond, similar to what Vermont's doing.
The next question, we talked about the dental benefits, but they also said, how will the ACA benefit women?
Good question. To benefit women. So, as you know, there's big issues around choice. Basically, abortion is not paid for by federal dollars, and that will stay that way in perpetuity, I assume, if Bart Stupak has anything to say about it. However, there are lots of provisions specifically related to preventive care that will probably benefit women quite drastically. There's been a disparity in existence for many years around cancer screening, around kind of preventive service use between women and men. Even though women are more likely to use healthcare, they're often less likely to get appropriate care. So the ACA has one provision that I just glanced over related to preventive services. So in essence, what the law says is that if you're a Medicare patient, a privately insured patient through individual market, small group market, or large group market, and your plan is not considered what's called grandfathered, meaning it didn't change any benefits since 2010, then you're entitled to preventive services for free without regard to the level of your deductible, cost sharing, etc. So you could have a $5,000 deductible through your employer, and if you went in for a mammogram and you're a woman age 40 or higher, and it's on the U.S. Preventive Services Task Force list as an A or B guideline or better, you will get it. Your insurer can't make you pay any portion of it. They have to give it to you, and your doctor won't charge a copay, right? And they'll get paid the full amount of the cost of that mammogram. So that plays out in colorectal cancer screening at a certain age, breast cancer screening, cervical cancer screening. It doesn't cover prostate cancer screening because the evidence there is below a B grade on the U.S. Preventive Services Task Force list. So basically, the law says if it meets the standard of evidence where it's either on the U.S. Preventive Services Task Force list as an A or B grade, it's on the IOM list for women's health, it's on the HRSA list for preventive services, or it's on the CD immunization list, all of those things have to be covered as preventive services by every plan, and they have to be covered at no cost by every plan. So all of a sudden, you end up with this wide variety of women's health stuff that is now covered free of charge, and that's why the birth control issue is so contentious, because of the fact that birth control pills ended up on that Institute of Medicine Preventive Services Women's Health list as a preventive service, and because the law was written the way it was, it basically said, we're not going to dictate right now what should be covered. We know medicine changes, we know evidence changes, so if a panel of experts tells us that this is a preventive service that has high evidence and high efficacy, we're going to cover it. And so anytime something ends up on that list, whether it's politically contentious or not, it's going to be covered, and that's where the birth control issue came up.
Okay, we're in the home stretch. Is there a way to control or prevent care denial, and a comma, by not allowing onerous bureaucratic process? I think that'll be kind of eliminated, won't it?
Right. Well, so care denial from an insurance standpoint is gone, right? So you can't be charged more or rejected from coverage because you have a condition. However, I think what you're probably getting at is, if I'm insured and I'm sitting there in the exchange and I go and try to get a certain service and the insurance company says no, what's my recourse? So it becomes complex. I apologize. So in the exchange, you're protected by the 2 state agencies that patrol and oversee health plans. So if you're in an HMO or a Blue Shield or Blue Cross PPO, you are covered by the Department of Managed Healthcare. And so you can call, I think it's like 1-800-HMO-HELP, and you can call and file a grievance and complain about a denial that has occurred, and they will follow up on your behalf, and they're usually very good about doing things quickly. If you're in a PPO that's not Blue Cross or Blue Shield, you're typically in the Department of Insurance because they regulate the other insurance products. They are less responsive, but I think they've gotten more responsive with Dave Jones. So it's a state issue. It's not something the ACA can necessarily do. That being said, the ACA kind of set out guidelines about what appropriate appeals and grievance processes are that states now have to kind of abide by. But California has usually been more aggressive on that than federal law, so I think things won't change much in California. One problem though is related to self-insured plans. So a lot of you, like if you work for the city of LA, you're in a self-insured plan. It's covered by a federal law called ERISA, the Employee Retirement Income Security Act, and it basically says the state government cannot make laws related to employee benefits that are paid for by the employer. And so if you're a self-insured plan, you're basically putting up all this money and you're saying we're going to operate the benefit instead of an insurance company. So sometimes they'll hire Blue Shield or Kaiser as their third-party administrator, but since the firm is the bank, they are self-insuring and they're buying a separate insurance policy that covers them from any loss. So they're really operating your benefit for you. And because of that, they're exempt from all state law related to appeals, grievances, and all those processes. And I think the numbers are something like 60% of the employer market in California is covered in a self-insured plan, even though you may not know it. So it may look to you like you have Blue Cross PPO, but in actuality it's a Blue Cross PPO operated by the trust of the Riverside Unified School District, and therefore you're a self-insured plan and you don't have the same recourse as somebody who's in the Blue Cross Blue Shield PPO product that is operating through the state insurance commissioner.
Would you repeat the HMO grievance information, contacting?
I think it's 1-800-HMO-HELP, but an easy way to get to it is just go to dmhc.ca.gov. So it's the Department of Managed Healthcare.
And there are online forms that you could just fill out and make your complaint.
So just to get back to, just so everybody's clear on the self-insured problem. So in that case, because you're governed by federal law and a self-insured plan offered by your employer, you don't have, the same state laws don't protect you. And you're also limited in terms of what you can sue for, and you have to sue in federal court because state law doesn't preempt federal law. So unfortunately with ERISA, like let's say you had somebody who was refused a cancer screening, and then they ended up with a cancer diagnosis and it cost all this money, it caused disability, and so it really cost in damages $1 million. All you can sue for in federal court in a self-insured plan is the cost of the actual service that you were denied. So the $300 for the colorectal cancer screening, not the $1 million in pain, suffering, etc. So being in a self-insured plan through your employer can be a little more dangerous than being in a completely contracted plan through the exchange or through your employer, where they hire the insurance company on your behalf, not use them as a third-party administrator. But that has nothing to do with the ACA. It has more to do why it's been so difficult for states to engage in healthcare reform, because there's always an ERISA preemption argument.
Interesting. If individuals opt out of insurance, what happens to them if they get sick? I think you pretty much covered that. They have to get a one-time waiver or
also,
coverage.
So open enrollment for the exchange will start October 1st, 2013 and go until March 31st, 2014. Once that happens and the first wave occurs, open enrollment will convert to, I think, October 7th to December 15th of each year. So it'll be longer than you typically see in an employer plan, but still a fixed amount of time. So really, to avoid adverse selection issues and sicker people holding out and waiting until they get sick, you should sign up at that point in time. if you lose your employer-based coverage, if you have a divorce, spousal death, you have a child, all those life-changing issues, you still, just like an employer plan, can sign up for a special circumstance. So you're basically allowed to sign up for the exchange due to one of those life circumstances changing. But getting sick isn't one of those life circumstances. So basically your job is sign up during open enrollment or go without coverage. You can sign up, so it's a guaranteed issue market, right? So you can sign up later, but your premiums can be priced differently. So you might be able to find a policy, but it'll be far more expensive than what you pay during open enrollment, and you won't be able to take advantage of those tax subsidies.
Even if you move out of state, for example,
Moving out of state would qualify you as a special enrollment circumstance.
and you wouldn't get jacked up prices?
No.
Oh, okay. And then
But I should mention, you can sign up for Medi-Cal anytime. So I'm just talking about open enrollment will exist for the exchange. If you're under 138% of FPL, you can sign up for Medi-Cal any day of the week.
Okay. And then, I don't know if I can read all this correctly. What about AB 12 bill that serves children who are wards of the court until they are 21? Many of them have mental health issues.
So I believe foster children and wards of the court will still be eligible for Medi-Cal. And that really doesn't change much. And what'll end up happening, as I explained in kind of the premium stuff, is like if you are a dependent of, let's say you're a foster child under a family and they're trying to sign up for coverage, they would use tax credits to buy their own coverage, but you would still end up in Medi-Cal because your income your income for the purposes of determining eligibility for tax subsidies is under 138% of FPL because you're this independent ward of the court with no where the family's income wouldn't factor in. So you'd end up with kind of split coverage for the foster or ward child.
Can I add to that? What I was trying, I guess, what I wanted to know is that most of the children, once they turn 21, they are out of the system.
I see.
They're out of your system. They're
Okay,
not out
yeah.
of the system.
Okay, well, most of them I see on the street.
Right,
In
okay,
a
got it.
cardboard
I
box
see
with
what
no
you're saying.
income.
Right.
Because there's
Right.
nowhere
So
else
now
for
they
them
don't
to
qualify
go.
for Medi-Cal.
Right, so I
They'll
want
get
to
Medi-Cal.
They will get
That's
Medi-Cal
what I wanna know.
after age of 21 if they're still earning under 133% of federal poverty level.
Can
So
I just say something to, you know what, that has to do with a lot of those kids are tagged mentally ill and have special issues. And the benefits that they get, that package, that they get up to age 18 and up to 21, that's what I was talking about when I said that falls away. And then they're left to SSI or the streets.
the issues do end up becoming pretty interesting, right? So California, we have welfare institutions code that basically says the county is a provider of last resort. So we've been living in this world for since the early 80s, where the state basically gave block grant money to the counties and said, run your safety net program as you wish with this pot of money. And the pot of money doesn't grow a lot, right? So we end up with LA County USC, Harbor UCLA being these big magnet public hospitals that care for the uninsured, and they see maybe 60% of their patient population is uninsured. They don't have lots of mental health services, right? So, and the funding is coming into Department of Health Services in LA County, but funding for mental health is coming into Department of Mental Health in LA County, and they don't share. So, mental health has said, well, we've gotten Prop $63 for the millionaire tax, and we're going to start co-locating primary care docs in our clinics because we want to meet the medical needs of this patient population that is disenfranchised because they're young adults, childless, have mental health issues, and the county doesn't do a good job, and they don't qualify for Medi-Cal. And now all of that kind of changes, right? All the incentives change, where now we're going to give them Medi-Cal, right? You're saying childless adults are now eligible for Medi-Cal, we should sign them up. And the benefit package includes all these mental health services that have been kind of split between Department of Mental Health, Department of Health Services, this patchwork of things out there. And now you're putting them in a managed care plan and saying, you get all of these things, and especially mental health is delivered either through the county or through this other health plan, but we need coordination to occur now. And that's something that hasn't occurred before, right? Especially in LA and the state of California, where the county agencies are always at each other's throats about funding, they're splitting, they have political arguments, etc. So it'll be interesting to see how it shakes out. I mean, the simple answer to your question is, now where they would have lost Medi-Cal at age 21, they will stay on Medi-Cal. And the benefit package will be exactly the same, it'll be free, and they'll be insured. They'll get mental health services through the Medi-Cal managed care plan for tier 1 and tier 2 things, probably up through counseling, and then for psych inpatient hospitalizations and substance abuse issues, they'll get this specialty mental health plan paying for their care. So they're covered, but it's really up to the providers to communicate within that plan, make sure people are aware of their eligibility for the program. In the state of California, we have 61% of our eligible population actually sign up for Medi-Cal. So we have lots of people out there that are eligible for Medi-Cal today and haven't signed up. And, I think that's a concern as well. So we need to do a good job of kind of making sure everybody knows where to get coverage, what they're entitled to, but also make sure that providers and insurance companies are working together to use the resources that are being allocated to them to take care of the population and improve people's health rather than just kind of, sit on their hands as we're used to doing.
Yeah, I want to ask a question based on that. Now, like I say, a lot of them have mental health issues. Now, some of them don't have mental health issues, and they are capable of getting jobs, but they just don't have the training or the know-how to go out and do these things. So what happens to them? Will they continue to stay on the Medicare?
Yeah, they would get, so anyone under the age of 65 who is a legal permanent resident or citizen who has lived here for more than 5 years will qualify for Medi-Cal based on modified adjusted gross income being less than $15,500 a year. Yes.
Quick question on Medi-Cal. I know a couple of people who are on Medi-Cal and in their late 50s. Are they going to have to do anything when this goes into effect? Do they just continue with what
Yeah, they
they've
would
got?
just stay where they are.
They don't
The
have
one
to
benefit
file
will be they'll
anything.
now have oral health coverage, but they don't have to
But
do
they don't
anything.
have to go online and do
Yeah.
anything.
So what will happen though is that it'll be easier to stay on Medi-Cal. So the next time they go through redetermination, they'll no longer get a questionnaire about their assets, things like that. What may happen in California is that the governor has asked CMS for permission to only give long-term care services to people who pass the asset test. And, that's a pretty typical thing.
Okay, thank you.
I have a couple of questions. First one is, if somebody is married but under 26, can they stay on their parents?
Yes.
Okay. And then what I heard
Now,
about,
one caveat. So currently they can. In 2014 they can, unless their spouse has an affordable offer of coverage that covers dependents, then they would have to join that plan.
okay, under the new Medi-Cal rules, and they're using your income tax, so if you are an adult who claim your parents for income tax purposes, and they're over 65, right now they could get Medi-Cal on their own based on their income. But my understanding is, I heard, and I don't know if this is true, because you claim your parents, that could compromise their Medi-Cal eligibility.
Right, so if you're claiming them as a dependent, where they're part of your household,
Right.
and then their household income is your household income.
So
Right.
people that qualify for Medi-Cal now could be jeopardized.
Well, I'm
by
not sure how they qualify for Medi-Cal. Things won't change in that regard, right? So,
Well, if they qualify now because they're over 65 and they have low income, right now, Medi-Cal's based upon their income. But if it's gonna be,
okay, so that aspect wouldn't change. Like, nobody who's eligible for Medi-Cal now will lose their coverage. What's gonna happen is they're going to go through a process called modified adjusted gross income conversion, where they're gonna figure out what the equivalent income would be after asset test and everything. But for the people who are now qualifying on like a monthly income, they would continue to qualify under the Seniors and Persons with Disability program because they're over the age of 65, and their income for the purposes of Medi-Cal eligibility determination is based on under 133% of federal poverty level. And so they would stay. The new expansion population
Right.
will be determined based on modified adjusted gross income, and the idea is that you can kind of choose between the two. So people could basically stay where they are. So I
Okay,
wouldn't worry
so if
about
somebody's turning 65 next year, and
that. Well, so you can always qualify under the old,
they
like,
could.
yeah, so the
Okay.
old rules will still be there. So the eligibility worker at the county would just have to kind of do it
Yeah.
correctly, set it up correctly, not try to qualify them under these new aid codes and qualify them under the old seniors and persons with disability aid codes.
Okay, one last question. So based upon that, because of old Medi-Cal, they divided income if you were unmarried or you had stepchildren. So if you don't qualify under new Medi-Cal because your income's too high with stepchildren and unmarried, then the county will look at that and qualify you under the old Medi-Cal rules?
I believe they are supposed to. Basically what will happen is the old Medi-Cal rules are going to be converted and updated so that they're somewhat equivalent to the new ones from a counting income standpoint. So they're supposed to move away from monthly income and all the complicated disregards. And so they basically hired Rand to do this rather complicated conversion methodology that hasn't yet been released.
Right,
So pending decision, I suppose.
okay.
Thank you. Anybody else?
I have a question, and this may not be the best place to ask it, which is why I'm only now asking it. For independent practitioners, like with me in mental health, for example, there's a requirement with HIPAA that we have patient records that we also convert to the electronic record keeping system, and that record keeping system has to be encrypted. I have gone all over hell and gone with my typewriter era brain trying to find where we can get access to that. And so far what I have gotten is, oh, you can't get that, that's commercial. It's only available to large institutions. So if we're going to be held accountable for tracking, maintaining client records in that kind of system, but we have no access to getting into that kind of a record-keeping system, and where does that leave us other than possibly losing our license?
Well, so you're not planning on getting an electronic medical record
I
system?
am, but
Okay.
I'm having trouble accessing the,
Right,
how
so-
can I get into that system?
So one thing you can do is Google High Tech LA. So that's your High Tech LA. It's HITEC space LA.
Wait, say that again?
HITEC space LA. So no H on High Tech. And that's the regional extension center for LA County, and I believe it's run through LA Care. So they basically got a grant from the federal government to, and this isn't ACA related, this is Stimulus Act related, right? So it's,
Right.
the High Tech Act is a part of the stimulus package that basically put all this money into getting providers to start offering, start implementing electronic health records. The idea being you don't need to implement an electronic health record if you're willing to take less money from Medicare. So if you don't implement, you would lose 1% in the first year, 2% in the second year, 3% in the third year from your Medicare fee schedule. But as a trade-off for taking the electronic health record, if you're a Medicare provider, you can get up to $44,000 in rebates. If you're a Medi-Cal provider, you can get up to $65,000 in rebates, I believe, to help you purchase the health record. Now, of course, health records are more expensive than that typically, and you get it, like you get half of it up front in the first year, then you get a quarter of it the second year and a quarter of it the third year. So over 3 years, you get $44,100, but you don't get it all at the same time. So the idea there is you either sign over your rebate to a medical group and they go buy an electronic, they pool all their physician's income and buy the electronic health record, or you try to find a web-based electronic health record that allows you to upload your data, pay a membership fee that your
That's what would be
rebate.
nice,
Yeah.
something
So there are
like that.
some of those products out there. I can probably find them for you. Like I know there are a couple out there that I've seen. I just can't think of the name at this point. But you know, I think this is a common problem where a lot of private practice docs don't want to buy a brand new server, brand new healthcare information system just for themselves. So they're willing to kind of buy into a web-based portal, upload the patient information, and be protected by their encrypted servers, and they basically have a membership or a subscription to it. The other thing you could do is if you're not going to do an electronic medical record, but you just want to protect the data, so basically scan all the material in, and there's free encryption software out there just to protect your hard drives. You don't have to worry about, or a server that you set up in your own office. You don't have to worry about actually doing the electronic medical record, but then you lose some of that Medicare reimbursement. So next year in 2006, or 2 years from now in 2016, you may get 97% of what you would have expected for every Medicare claim you submit because of the fact you don't have an electronic health record that met meaningful use criteria.
Well, I was willing to do it, you know, I started out with Best Buy and Verizon and
Yeah, so I would go with,
they just laughed me
I would just
away.
go to High Tech LA, and there are a bunch of vendors and grantees under that award that will help providers kind of get set up and guide them in the right way.
So could you tell, I mean, they don't, these programs don't do the billing. All they do is keep a record of your,
Right, so typically a billing system will be separate, although there are quite a few that are integrated somewhat. So some people have an electronic medical record, but they still have somebody doing medical coding and billing separately manually. And then some, I believe, like they'll integrate into a practice management system, like a PMS, that will then do the billing for them or set up everything appropriately into the right CMS 1500 form and let you submit it. So you kind of have to shop around for the right product. I would argue that probably for these web-based ones that I just described, they won't do the billing, right? So you're going to still be reliant on whatever system you currently use, even if that's you know, something fairly archaic, as long as it does electronic submissions to Medicare and other providers.